We're broadcasting to Facebook. Exciting. Okay. Cool. All right. Get that guy in there. Nope. I think that'll do it. Hopefully it doesn't fall off mid-presentation. Is there anybody on yet? Oh, yeah. Cool. There we go. All right. Okay, for anybody who's tuning in online, we'll start in just a couple minutes. Oh, that's it. So glad we did it. Just like a touch. Not there.
I won't know for 30 seconds.
It's like there's
How
a.
close it got.
Okay, that's not too much. It's not as lagged. That's good. Okay. Cool. All right. Thanks for coming, guys. Now we're like in the middle of a global pandemic that's starting to rise again, but hopefully everybody feels safe enough, like separated from each other, 6 feet apart. Hello, everybody online. Thanks for tuning in. If you can't hear me or have trouble seeing the slides, just let me know. Rachel's on standby with the live feed so that we can, answer questions and all of that. So tonight, there was a post in the Moms of Edmond group recently about Diastasis Recti and what to do about it. So we're gonna look at it from like a rehab standpoint and anatomically. We're gonna look at a couple of other things too. So we're gonna talk about different types of incontinence after pregnancy, so like peeing when you don't want to. And then we're also going to talk about when it's safe to return to the gym after different kinds of births. So these are just things like once we're like, hey, let's do this presentation, just ideas that people came up with for, just to talk about and just stuff that we treat here in clinic. So without any further ado, here we go. Okay, so like I said, diastasis recti, the pelvic floor, and then returning to work out after giving birth. 3 really important things, just kind of after having a baby, we don't really know. We're just like, we get this baby and it's like, hey, now what? Like, what do I do with my body? Like, I'm not really sure. And so these are 3 of the most common things. And hopefully after this, you'll be able to have a little bit of an idea of where to go next with your own self and if you need further assistance. So in every presentation, there's a disclaimer slide. This is just informational only. I'm not diagnosing anybody via video, whatnot. Like, it's just something, if you think it applies to you, we can take a look. So it's just that we're talking about the common methods for treating these conditions. And then also, for this particular presentation, there will be adult content, which for you guys here, not really a big deal. But if you're watching at home, you may want to keep that in mind if you have little kids around. There will be slides that are a bit graphic that show women's anatomy, pelvic anatomy, and there'll also be talk about different functional activities related to the pelvis, if you get what I'm saying. Okay, so diastasis recti, we'll start here. What is it? So everybody has what we call a linea alba, which is tissue in between both of the rectus abdominal muscles that hold it together. It's a fascial connection. So it is really common, even in somebody who hasn't given birth, to have a space in between there. That's normal. There can be up to a 2 centimeter space in between our abdominals, and that's completely functional, normal, and whatnot. So when we are pregnant, our anatomy expands to allow room for the baby, and that's going to stretch the rectus abdominis long ways, and then it's going to separate. Okay, this is normal. It just allows room for growing baby, and so it is pretty common. 1 in 3 mothers will have this postpartum. It's more prevalent following C-section births. It's more prevalent in multiples, so twins, triplets, etc. And then the more pregnancies you have, there's going to be more frequency of this. Usually about 6 weeks postpartum, this completely goes away or returns to your pre-existing abdominal condition. Anything after that, is when we're looking at something a little bit more, I don't want to say severe, but a little bit more involved. So, there's different types of diastasis too. So, here in the first picture we have normal. Everything is pretty symmetrical going up and down. You can have below the navel, so we're split open underneath. You can have above, split above it. You can have around the navel, so just like a little circle around it, or you can just have the whole thing. It's just wide open for the world. So, the treatment's pretty similar for all of them, or, self-treatment for it. But before we get into that, I want to talk about how we grade it, how we measure it, and how you can check for it in yourself. So the way you check for it yourself is going to be very similar to how a clinician will do it for you too. So grading, like we talked about a little bit before, typically it's measured in centimeters, but clinicians a lot of times will measure it by fingers. So like 2 finger width, 1.5 finger width, 3 finger, 4 finger, etc. And so that's pretty much how we'll, so to speak, chart it. And so if anybody has anything wider than a 2 finger, that's something that I'm going to be looking into giving a full-blown treatment plan for. So how do we measure it? We're going to go ahead and get somebody down in this position. And Rachel, I'm going to have you go ahead and lay on the table. I'm just going to turn this real quick. So when we measure it, all right, go ahead and lay down on your back for me. Okay, so I'm going to come to the other side of you. I'm going to come all the way around. So when we're measuring for it, we want to measure in a couple of different places. I'm going to touch your belly button. Is that okay? All right, so I'm going to find your belly button. For the sake of time, I'm just going to have you, yeah. Okay, so once I have the belly button, I'm going to go ahead and make sure that I'm kind of dipped in between both rectus muscles, the abdominal muscles. I'm going to have you go ahead and lift your head, and then I'm going to see if my fingers can slip into the space in between the 2 muscle bulges, and then go ahead and lay back down. Now I'm going to go about 1 centimeter to 1 inch above her belly button. Go ahead and lift up. Okay, and I'm going to kind of feel around and see there, and then go ahead and lower down, and then I'm going to find the belly button again and go about 1 inch lower, and then go ahead and lift. And I'm going to assess in all of those places and just see how much finger width I have in between both bulges of the rectus abdominis. Go ahead and relax and chill for a bit. Okay, so that's something that you can do to yourself at home. You can lay down flat, find the center of the abdominals, find your belly button first, and then you'll go ahead and lift up and feel in between to see just how wide that is. As your pregnancy progresses, this is just normal. You're going to have it, so you might as well wait until afterwards to assess it. So how do we treat it conservatively? Breathing is super, super important here. Something big with Diastasis Recti, if you've heard the phrase taking the path of least resistance, when we have intra-abdominal pressure, like sneezing, coughing, etc., the pressure needs to go somewhere, and it's going to go where there's like a breach in the system. So if you have this opening in the abdominals, it's going to make it, that's going to be a very convenient place for the pressure to be expelled. So the first thing that we want to do is we want to make sure that we're breathing correctly, using good belly breathing, diaphragmatic breathing, and that we're not bearing down on our pelvic floor, so that we are getting good, just like a good pressure system. And the best way to start that is to make sure breathing is good. Another thing too, so the way that our abdominals, we have 4 different abdominal muscles that make up the abdominal sheath. So we've got the rectus, which is the up and down and the most involved here in our diastasis. we've got our external obliques. So if you take your hands and you put them like you're wearing a pair of pockets, or like you're putting them in your pockets, these are your external obliques. They run diagonally, going top to bottom. And when we turn, we contract the one. So we call it the same side. So basically, I'm contracting the left when I turn to the left. I'm contracting the right when I turn to the right. Now our internal obliques, we cross those hands, and the fibers are running the opposite way diagonally, and so those are going to be the opposite side contracts. When we turn one way, the opposite side contracts when we turn the other way, and those are going to help to kind of cinch everything back together. So our rectus is up and down, right? And those, when we come up, they're just going to kind of spread apart if they're not held together, but the obliques are going to kind of cinch it down diagonally, top to bottom, top to bottom. So we'll talk about that in a little bit. More importantly, transverse abdominis, our deepest abdominal. So this one is under all of the layers, and that one actually kind of, the fascia comes around to the spine too. So the transverse abdominis, this one we strengthen, and that's going to flatten the whole abdominal sheath. So getting that to strengthen is going to help to bring everything together as well. However, we want to make sure we're using gentle strengthening here so that we're not overdoing it and creating something that's going to overcompensate. And then also education. Education is really important when it comes to this stuff. Just knowing what to do for it and what not to do for it is going to help us to heal it appropriately. So I've got 3 different exercises that we're going to talk about today that you guys can take, pretty much take and bake, so to speak, and bring with you. One of them is going to be breathing. Another is going to talk about abdominal draw-in and the posterior pelvic tilt to help strengthen the transverse abdominis. And the third one is going to be some oblique strengthening, okay? Just a note, when it comes to diastasis, we don't want to do a lot of head-up, curl-up type things. That's going to exacerbate the split, okay? So we need to get things a bit stronger before we can move into those. That's going to be an end of the line kind of exercise when things are firmer. Okay, so I'm going to have you lay, or actually stay seated first. Yeah. So we're going to talk about breathing first. We're going to talk about a diaphragmatic breathing. Okay, so I'm going to put that there, and then I'm going to have you, and everybody here, and anybody who's watching, you're going to put one hand on the front of your belly, like right under your rib cage, and one hand behind your back. So now, when she's breathing, I'm going to cue her to take a big deep breath, and I want you to feel like your chest is expanding, and the air is expanding into your belly, and the air is expanding into the back of your rib cage. Okay? As you're doing this, you're going to inhale through the nose, feel all of those areas expand, and then exhale. Okay, we're going to do 2 or 3 like that. And you want to really fill up the chest and the belly with air. Fill up the back of the rib cage. Get a nice 360 breath. Good. You also want to feel like you're relaxing your pelvic floor. So feel that you're not clenching your butt, not clenching your legs, anything like that. Just take a few nice deep breaths. Good. And that's some breathing that will, take over into our other exercises as we do our abdominal strengthening. All right, I'm going to lay on your back next. Cool. So this next one, I'm going to come around again. The next one, we're going to talk about a posterior pelvic tilt or an abdominal draw-in. So for this one, we're going to pay attention to the pelvis. I'm going to place my hand underneath Rachel's back, just the small of her back, and I'm going to cue you, go ahead and just tuck your tailbone and press your low back into the table. So she's going to flatten her back, her head, neck, and shoulders stay relaxed, and her butt stays touching the ground. If anything, her tailbone just kind of lifts up a little bit. She's going to hold 3, 2, 1, and then relax. And then the space returns under her back. And then she's going to go ahead and flatten it again. And she's going to hold it. And we're not really clenching the buttocks. We're not really putting any tension in the shoulders. It's just the abdominals. They're going to naturally contract when she does that posterior tilt. And then you go ahead and relax. Okay, so that's another good one. And that's a good one for strengthening the transverse abdominis. And also just retraining those abdominals to work more efficiently. All right, the next one, I'll have you sit back up for me, please. couple of different ways that we can do this next one. You can be in seated, or you can be in half kneeling, or you can even do it cross-legged or standing. So I'm going to take a TheraBand. I'm going to place it around the pole. Alright, I'm going to have you go ahead and grab on there. And you're just going to bring it straight in front of you. Good. So what I want here, I want her lumbar spine to stay steady. We just want thoracic rotation here. So you're going to go ahead and let your shoulders turn, but keep everything under your rib cage steady. So abdominals pull in, and you're going to bring the band back to center, maybe a little bit further. Yeah, and then come back. And this is working our obliques, strengthening our obliques. You can see that we're not crunching into a flexion position. Our abdominals pretty much stay nice and straight up and down, so nothing that's going to increase the gap, but we are going to strengthen some muscles that are going to help to stabilize both ways and inward. Okay, we'll do 2 more just for put on a good show.
Smile.
Good. Smiling through that math. Good, 1 more. Cool. Okay, so those are 3 great exercise suggestions of things that you can do that are going to help to gently and safely strengthen abdominals to not exacerbate your diastasis and help to reduce it. The next thing, I'm going to be like smooth. Okay. So the next thing that we're going to talk about are a couple of other methods. Okay, so taping in general, I'm not like a huge fan of kinesio taping for just a lot of different reasons. But some practitioners will use kinesio tape to bring the diastasis back together, to hold it back together. Now you can see, if you, like earlier when we were talking about external, internal obliques, you can see that the fiber orientation of the taping, we're pulling everything together, just like using those external and internal obliques to your advantage to help use your own muscles to make that center moving corset of your own abs. And I guess that kind of brings me into the reason why I don't really love taping or bracing, relying on it, because I want you to use your muscles instead. Like use your muscles to your advantage to help reduce it. There's also the noble technique. So we talked about not lifting your head up. However, with the noble technique, we can still do rectus and flexion abdominal strengthening, but we take a sheet or something and we cinch it across the stomach so that it holds the muscles together, so that when we do lift up, the sheet is pulling it back together. And we can still get that strengthening without exacerbating the split of the linea alba. Okay, and then the last thing that I want to talk about with diastasis is surgical repair to it. Okay, so if you go to a surgeon's gonna like surgery. If you go to a physical therapist is gonna like conservative methods. So keep that in mind when I talk about this slide. So typically a diastasis repair is going to need to be done by a plastic surgeon. These are the types of surgeons that's going to do that for us. And there's pros and cons to any surgery. So pros, you're going to decrease the gap between the abdominals immediately with the surgery, and it's also going to improve your aesthetics right away. So, that's definitely a lot of the reason why women do it. They don't want the look of it anymore, and sometimes the diastasis is just too severe to bring back together. Cons, with any time we cut into the body, there's decreased proprioception, so that means the body's ability to realize its position in space. So to make it simple, if I'm not looking at my hand and I go up, down, up, down, up, down, I know my hand is up because of my proprioceptors. Okay, so similarly, anytime we have surgery, the muscles need to re-educate themselves because they've been cut into, sewn into, whatever. And then we also have sensation issues cutting into the abdominals or cutting into the skin above the abdominals. And then most of the time, most plastic surgeons require you to have a tummy tuck as well. So a little bit more extensive recovery from that. And then it's going to be an out-of-pocket expense because plastic surgery, most insurance plans aren't going to cover plastic surgery unless it's something medically necessary. So like let's say your diastasis was causing a terrible hernia, maybe that you could get it covered by insurance. Okay, And just a last note about diastasis. So earlier when I was talking about measuring it, I forgot to mention there's a couple of other little nuances that go into it. So when you push down, sometimes you might have a space still, but it's very firm. That's a good thing. So the linea alba, sometimes it just doesn't come back together no matter how strong you get it, but as long as you have that firmness of the tissue, you've built it up, stressed it in a good way, and it's going to protect the abdominal contents. It's just going to be a little bit wider. And then if you are assessing it and it's squishy, that's when, okay, we still have a pretty significant issue because the linea alba, it hasn't built itself back up yet. So it just depends, woman to woman, everybody's going to be different. And then from there, if you've done everything you can and you still have a significant gap, but it's nice and firm, sometimes women would want to look into the plastic surgery for the aesthetics of, okay, I want my abdominals to look like they're together. So there's that. All right, the next thing, the pelvic floor and peeing when you don't want to. So after giving birth, and even when you are pregnant, like, you know, every time I sneezed, I'd pee, and it'd be terrible. So, you know, if you've ever had that happen to you with some sort of an incontinent issue, so whether it was during pregnancy or after birth, this next section will talk a little bit on that. There's 4 types of urinary incontinence, okay? Typically, with pregnancy and postpartum, we're looking at stress incontinence, and this happens with leaking urine during activities like coughing, laughing, sneezing, exercise, etc. Urge incontinence is when you think, so this one is a little more abstract, so you have the mental urge to go to the bathroom and you can't make it there in time. You can't, it just happens. Mixed incontinence is a mixture of both of those things. And then of course we have a temporary incontinence when we have some sort of illness like a bladder infection or a urinary tract infection, etc. So there are those things when it comes to incontinence. So why does it happen, basically? What is our anatomy doing that makes this happen? So in everybody's pelvis, and this is a slide looking, if somebody were laying down and their legs were towards you, we're looking up into the pelvic girdle. So the pelvic diaphragm is made up of 3 muscles. So it's called the levator ani, and it's composed of the pubococcygeus, the puborectalis, and the iliococcygeus. And we now know that all 3 of these muscles contract as a unit. So a lot of big things going on there. But the bottom line is that these muscles are, when you're doing a Kegel, this is what we're contracting, okay? So when we're looking at the anatomy here, so let's see. So the pubococcygeus kind of comes around all of our sphincters. So our anal sphincter, our vaginal opening, and our urethra are all surrounded by these muscles. So when they contract, they're squeezing on those inert structures, so they help us to control those functions. They help us to control bowel and bladder and different sexual functions. So when it's weak or tight, we may have trouble with pee, okay, or with bowel movements, or you know, typically with other nitty-gritty women's health issues, pain with sexual intercourse, etc. Decreased sensation. So like I said, Kegel muscles are what we would do to strengthen this area. Now, we don't always want to just throw Kegels at a problem. You know, Kegels aren't always the answer. So with this particular area, we've got what we call tight versus weak. Okay, so peeing with impact, like running and jumping, pain with intercourse, feminine product usage could indicate a tightness of the pelvic floor musculature. So some ways, if you're like, well, I don't know if I'm tight or weak, and that's why I'm peeing when I'm running, those are a couple of different like self-tests that you can do. So if it's painful inserting feminine products, painful during sexual intercourse, you may have a tight pelvic floor levator ani. So that's something to look into. Now, if you're weak, this would be the inability to prevent urination and wind passage. Also the inability to clamp those muscles down on something inside. So that could be a weakness in your pelvic floor muscles. So that's a way that you can kind of get a beat on it on your own at home before speaking to a professional about it. So treating tight muscles, this is a nice brief slide. So butterfly butterfly stretching is one of the basic things that I would recommend to people for stretching these type muscles. So if you wouldn't mind, Rachel, I'm going to have you sit on the table and face that way for me. And so for the butterfly stretch, I'm going to have you just go ahead and bend both knees and put your feet together. Okay? And then you're going to grab onto your toes, keep your lumbar spine nice and straight, and you'll just lean forward. And she's going to feel a stretch in her inner thighs here, correct? Yeah. Okay. We hold that for about 30 seconds, 3 times through, maybe once, maybe twice a day, depending on your symptoms and how you're feeling. So there's a lot more that goes into that, but that's just like a nice thing that you can try to do to make it feel better. Okay. So now, going into strengthening a weak pelvic floor. So here's where we start to get a little bit more in depth. So we're going to talk about the Kegel here. So Kegels are how we would strengthen a weak pelvic floor. Now, when a lot of people come in and they're like, what's a Kegel? Like, I don't understand what you mean. What am I contracting? So a way that you can determine this on your own at home, when you're in the bathroom and you are urinating, you want to wait until you're just about done, and then you're going to stop the flow of urine right before you're done when there's just a little bit left, without clenching your stomach muscles, your butt muscles, or your inner thigh muscles. You're just using your pelvic floor, specifically your pubococcygeus. So that's how we know. I know it's a very abstract thing. These are also the muscles that you would hold in to hold not going to the bathroom or stop breaking wind. Okay, so with Kegels, what I'll tell people a lot of times is consider doing it in different positions. Start just seated in a chair, nice and comfortably, or start actually when you're on the toilet. So like after you finish going to the bathroom, you can try to do your Kegels. It's a great place because you're there. Every time you go to the bathroom, you do a couple of Kegels. Good way to remember. If sitting, it's just not working for you, you can try it laying down, you can try it in standing, or you can try it on all fours. Sometimes being in a different position helps you access the muscles better mentally and physically. So that would be my recommendation there. Another one you can do is you can get into a wall sit. So squats help to strengthen the pelvic floor, but also we can double down on that and perform a Kegel at the bottom. I would recommend going to about 90 degrees and then going from there. That's a little bit more advanced, but a little bit more functional. There's 2 different types of Kegels. So the levator ani, or the pelvic floor muscles, are comprised of 70% slow twitch fibers and 30% fast twitch fibers. What that means is a slow twitch fiber is more of an endurance muscle, so like holding your pelvic girdle all day, muscle-wise, or holding a long contraction is the best way to describe what slow twitch muscles do. Fast twitch muscles are more your big power things, so like when we sneeze and cough, the fast twitch portion of these muscles are going to help us to not pee. Okay, so we need to work both of these things in order to have a nice, strong, fully complete pelvic floor. So a slow Kegel, you want, and the best way to kind of portion these out or think like on even days I'm going to do my slow Kegels, and on odd days I'm going to do my fast Kegels. So slow Kegels, you're going to hold the contraction for 3 to 5 seconds. You want to hold it for a prolonged period in a slow count, and you're going to do it about 10 times. So if you're doing it every time you go to the bathroom, like 10 times is plenty. And then fast Kegel, you're going to perform 20 to 40 quick flicks. So it's just like a quick flick, 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 flick of the muscle. Now, you want to do this until you fatigue. So 20 to 40, I was reading like some literature today about like 40 to 60, and I'm like, that's a stretch. That's like a lot of those to do. So you're just going to build yourself up until you fatigue, and you'll do as many quick ones as you can until you fatigue out. And that's going to help strengthen the fast twitch muscles there. Okay, so bringing it back to like pre-postnatal type things. So the levator ani in pregnancy, so this is greatly stretched, especially in delivery, and the baby sits here for the duration of your pregnancy, especially as you become more pregnant. Specifically, they're going to sit on the iliococcygeus portion of it. So this outer portion of the muscles is going to hold there, it's going to stretch. That's a long time for that to be happening. A stretched out muscle is a weak muscle. So keep that in mind in your postpartum. You know, this is probably the reason why we might be And then also, these can definitely be damaged in childbirth. There's a huge stretch that goes on, and upon delivery, you can have damage to the muscles. You'll likely know this following birth, right after. It's not something they'd be like, oh, I wonder if this happened to me. You will likely know. Okay, cool. Okay, so that's everything on the incontinence. And now the last thing that we're going to talk about is returning to the gym after giving birth. So when is it safe? This is a question that we get a lot. So your pregnancy went great, rocked it like a queen. Now you're going to want to let your body recover appropriately. So with most things, the more active you were prior to pregnancy and the more active you were during pregnancy, the easier your recovery is going to be. And you'll have, it will definitely affect your postpartum outcomes. So we have significant rapid changes to the abdominal core, and we have rapid significant growth in all of these areas, and then we also have a lot of stress and stretching to the pelvic floor muscles like we just talked in our last slide. And then also the type of delivery is going to make a big difference. So vaginal birth versus C-section. If you had complications, did you have an episiotomy? Did you have any perennial tearing? Did you have a C-section? Was your C-section planned and smooth? Was your C-section kind of crazy and had you all around? Okay, these are all things that are going to determine, when you're safe and when you feel good about going back to physical activity. So with the vaginal delivery, there's usually about a 2-week limitation on doing anything crazy as healing occurs, and then around 6 to 8 weeks is when it's going to be safe to go back to the gym. And that's not just like no holds barred, let's go party. You want to really ease yourself into that. So if tearing occurs, then you're going to want to consider waiting a little bit longer for returning to physical activity. And with Kegels, you're going to want to hold off until 3 to 4 weeks postpartum, especially with a grade 3 to 4 tear. Grade 1 and 2, you're going to let pain be more of your guide. But typically you can do Kegels immediately, like once you feel good to do them after birth, as long as there wasn't any tearing. So you're going to want a gradual return to exercise after this type of birth. So squatting and jumping are going to require great precaution, because with squatting, that's where we're going to have the most stress on the pelvic floor, and jumping, if we don't have that pelvic floor strength and stability, then we might have the leakage, we might have some increased stress that we're not ready for on those muscles. So pelvic floor impact, so think about when you're at the gym, plyometrics, jumping stuff, box jumps, things of that nature, then jumping rope, running, and then of course squatting. So like we talked about in our incontinence slides, because these muscles were so recently stressed out and stretched out, they're gonna take some time to recover. Just like if you had a muscle that was significantly stretched out over time, you would want to let that recover as well. You can begin with Kegels a few hours after birth, with the exceptions that we spoke about. And of course, you want to be careful and not do anything that causes you pain, and just make sure you have your OB in on it so that they know that this is what you're intending on doing, and that they don't have any concerns about you starting Kegels shortly after birth. Another couple other things, just a side note to think about with higher impact stuff. It's not just the pelvic floor that we want to look at. We want to look at your lumbo-pelvic stability as well, that you can stabilize when you're doing these things. And we want to look at making sure you're absorbing shock correctly. So if you're not doing those two things, if you're not stabilizing lumbo-pelvic and you're not absorbing shock correctly, then that could also lead to leakage or overcompensation of the pelvic floor muscles. Okay, so a timeline for a normal vaginal delivery, 0 to 2 weeks, we can be walking with baby in the stroller, we can be doing our Kegels, we can be doing gentle core strengthening like Rachel and I did with the posterior pelvic tilts, and some variations on that. 2 to 4 weeks, we can do some hip strengthening, standing strengthening, like standing at our stroller, doing heel raises, hip lifts, things like that. Maybe some activity-based exercise with modifications, as long as it's low impact. 4 to 6 weeks, we can start doing some more sports-based activities, as long as they're low impact. I know a lot of CrossFit moms might go back around this time, but just like really, really modify things and keep it very low impact. core. 6 to 8 weeks, start with your return to sport with caution of impact exercises and squatting. You're gonna let pain be your guide. You're also gonna let leakage be your guide. So if you're doing something and you feel like you're excessively leaking, that's a warning sign of, okay, what do we need to troubleshoot here? Maybe I shouldn't be doing this. So there's that. Now, cesarean section is a little bit different. And like we talked about, not all cesareans are the same. Some are, nice, you go in, they're easy, get in, they get out. And some of them are a little bit more like, okay, we need to get this baby out right now, and they're a little bit more aggressive. So there's different incision sites. Most of the time now we're gonna see things that are very low and suprapubic. So right above the pubic bone. Very rarely do they do a midline vertical anymore. Sometimes we'll see it if somebody's had a previous abdominal surgery and they have that incision already, they'll go back in through it. But typically we've got a small, lower suprapubic incision. So we cut through a lot of layers. There's 8 layers that we cut through in a cesarean delivery. I'm sorry, this is the graphic slide. I forgot to warn everyone, but it's not too bad. So we're cutting through most superficial to deep, the skin, adipose or fat tissue, external obliques, internal obliques, transverse abdominis, rectus abdominis, the broad ligament that covers the uterus, and then finally we cut through the uterus to get to baby. That's a lot of layers to get through. There's a lot of things involved there. We've got what we call contractile tissues, which are your abdominals, and we've got inert structures and smooth muscle with your uterus. So a lot of things to heal as we recover from a C-section. So we want to be really gentle with our body. So I would say post C-section is something that we get a lot here, and as well as diastasis, but with this we see a lot of core insufficiency. So we've just had a big, so there's a lot going on there. We're going to have scar tissue and we're going to have sensation issues. There's just going to be lack of sensation with feeling the contractile tissue, so being able to feel the muscles contract. There's also going to be hypersensitivity sometimes, so like around the scar tissue it feels very uncomfortable when we touch it, when hands touch it, etc., because the nerve endings are starting to kind of come back together, and sometimes they just freak out. So a couple of different things there. I would say person to person it differs. It would be about 4 months or 16 weeks until you can kind of start feeling lower abdominals give you a contraction. It'll do it. The muscles will do their thing, but it'll be very hard to feel it and to like mentally regulate it. So that's something that we have to work through to get the core working well again. Otherwise, we can have lumbopelvic issues again. We're not able to brace for certain activities, and we have more pain in abdominal, low back, pelvis, etc. So progression to our 8-week post C-section visit. So with C-sections, you're going to see your OB at 2 weeks. You're going to see your OB at 8 weeks. So getting you to that 8-week visit, 0 to 2 weeks. Walking as far as pain allows. So you're going to want to increase that a little bit each day, but once you start feeling that pain deep in your abdomen, you're going to want to turn around, go home, and rest. And then no lifting anything heavier than baby. So 2 weeks, we take it real easy. We're really gentle with our body. We just we survive a newborn with an abdominal incision in ourselves. 2 to 4 weeks. We're going to start working on our breath work more. So like we talked about earlier with the diastasis stuff, that nice belly breathing, getting that good 360 breathing. We can do some standing hip work with the baby stroller, pain being your guide. So our heel raises, our hip lifts, you can do some marching if it feels good. 4 to 6 weeks, we'll start doing more advanced hip strengthening, like bridging, clamshells, and we can start some posterior pelvic tilting to start strengthening abdominals as long as it feels okay. 6 to 8 weeks, we can do some modified side planks, the noble bracing curl-ups, where we pull the sheet around us, some lateral banded walks if they feel good, so starting to get things a little bit more functional strengthening. And then around 8 weeks, well, this should say 8 to 12 weeks, we'll take a gradual return to sport. And this isn't like, okay, go nuts, it's, okay, take it day by day, see if it feels okay, do a lot of gentle things, and then progress as your body allows it. Making sure you're using good form, etc. All right, so if you're still, after all of that, if you're still having issues or you just feel uncomfortable with, tackling it on your own, I would seek out a physical therapist who's comfortable with women's health issues. Just because they're gonna see it more often, they're gonna know how things work. and they're gonna specialize in this type of thing. So they're gonna give you the best care that they can. And then the final note to it is just be kind to your body. It just did a really big thing, and you know, there's a lot that's gonna happen afterwards with the fallout from it. But you know, just take it day by day, and you know, just go from there. So that's it. If anybody has any questions, just let us know. I think there's like a 30-second lag on the live, so if any questions come up, we'll hold off for that. But otherwise, thank you guys so much for coming, and I hope you learned some valuable information.
Thank you.
Yeah. Bryce loved it. You better love it.
I like how you had to sneak a pic of Kat up there.
Yep. So yeah, definitely self-serving presentation. Look at the kid, she's so cute. They're also like, hey, I'm a mom. I know what it's like. Yeah, I'm a C-section mom. So that last part, I had made a protocol for Lakeside. So the last thing that we saw, the 0 to 8 weeks, typically if you have a C-section there, a couple of the doctors will give you that protocol so that you have something tangible to be like, okay, here's what I'm gonna do. That one's a lot more in depth. There's a lot of precautions and things like that. So if you are interested, I can email it, or if you know somebody who's recently had a C-section, I'd be happy to share it with them too. So.
Isn't the live video on you guys' page, or was it on the, okay.
Yes,
I'll
so
find it.
we'll post it, like, you know, afterwards when you stop the video, and you can post it. So like if you know anybody who wants to watch it, they can watch it. And just, you know, reach out. There's some cards on the desk if anybody would like one, but we're here if you need us. And that's pretty much it. Yeah, there's also candy on the desk, so please don't reach out to that. Bryce and I talk about this all the time. I don't like doing presentations without like snacks, because there's like 100% chance that I'm going to attend a presentation if there's good snacks. You know, it's like, oh, we're talking about lizards, great. I can learn while I eat this. Alright, cool. I guess there's not any questions. Awesome. Alright, thanks guys.
Thank you.
Feel free to stick around. I'd be happy to assess DR if anybody wants me to take a look. And then, yeah, if you have questions, just let me know. I'm going to turn off the live feed now. Finish.